Because folks need to maintain access to Medicaid, especially home and community-based services, they decline work, they decline promotions, they decline extra hours.
Why do you think disability is so often treated as a separate from mainstream health policy conversation? Disability policy is often treated as separate from healthcare, but in reality, it's deeply connected to how people access and experience primary care every day. For millions of Americans with disabilities, primary care isn't just about routine checkups. It's shaped by Medicaid coverage, long-term services and supports, and whether the system is designed to meet their needs at all. Today, I'm joined by Rachel Patterson, a national disability policy expert and former disability policy director at the White House Domestic Policy Council. Rachel has spent her career working at the intersection of healthcare, civil rights, and policy, bringing a real-world lens to how systems actually function for patients. In this conversation, we'll explore why disability policy is primary care policy, where the system is falling short, and what it'll take to build a more accessible, responsive healthcare system for people with disabilities. I'm really excited for this conversation, so let's dig in. Hi, Rachel. It's really, really great to be with you today, and we're so excited to have this conversation. Before we get started, can you just introduce yourself and tell us a little bit about who you are and what you do?
Sure, yeah, hi. I'm Rachel Patterson. I am one half of Patterson and Meek now, which is a tiny two-woman health policy consulting and lobbying firm. We do public policy analysis, regulatory writing comments, classic lobbying and government relations. But my background is all in health and disability. I came to DC wanting to do that, and I have had a number of different jobs in advocacy, working in epilepsy, in spinal cord injury, in research. But then immediately before my current job, I was at the White House. I was the disability policy director for the Domestic Policy Council for the Biden-Harris White House, which is a mouthful.
Yes. But a really important job.
Yeah, it was great. It was, definitely hardest thing I've ever done.
Yeah.
But also extraordinary experience and opportunity.
Yeah, amazing. Well, there's just this is one of the things that I love most about these conversations is that everyone comes with this incredibly rich background and so many different experiences in health policy and sort of in the field and otherwise. You being one that we can add to the list now, but I'm excited because we have a bunch of questions, so I'm excited to dive in if you're ready.
Great. Yeah.
Okay. So one of the first questions right off the bat is that when we say patients with disabilities, what does that actually include, and what do people tend to misunderstand about the population?
Yeah, it includes more than a lot of people think.
Yeah.
I think people think of, someone who uses a wheelchair, especially you drive around, you see the parking space, it's got the little stick figure in the wheelchair, that's what they think of. But disability encompasses such a broader range, including people with mental health conditions, people with chronic illnesses, people with intellectual and developmental disabilities. And some of those are invisible. Invisible disabilities is a phrase.
Yeah.
And so it's a much broader population than your average person thinks about in their mind.
Yeah, I appreciate you bringing that up right off the bat, just because I think that is one of the biggest misnomers and challenges we face. We think about people with disabilities, or even just sort of ableist conversations in general, is that if you can't see it, it's it's an easy assumption, and it's not necessarily with poor intention, but it can be really harmful.
Yeah.
But why do you think disability is so often treated as separate from mainstream health policy conversation?
Yeah, I think it's really rooted in the history of disability itself and how it's treated in society throughout history, but especially the 19th and 20th centuries. Disability, a lot of how society treated disability was by removing it from society, be that forced institutionalization, no schooling, not even at times, if you look back really far in history, saying you're not allowed to be out on the street because we don't like how you look. Yeah. So if you build your society based on that, then the assumption is that you're not really part of society.
Yeah.
And so you're not going to be part of health policy either.
Right.
Now, the history of disability rights is trying to be a part of society and a part of the community and a part of the way that everybody else lives their lives. But that's work we're still doing in health policy.
Well, so question to go a little deeper into that. Can you just give a little bit of to speak to the history, and I might be wrong on this,
okay.
But we just had an important anniversary with Medicaid, but can you speak a little bit to because to me, Medicaid was one of the first intentional sort of engagements around supporting and addressing people with those types of needs and disabilities in particular. Am I right on that? Or where would you track the history in terms of like, when did we start really understanding and paying attention to this and leaning into it differently?
Well, there's leaning into it differently. So I would say before you had Medicaid, you had state psychiatric hospitals. You had the institutions for people with epilepsy, for people with developmental disabilities. Those existed well before Medicaid came along. Then you get Medicaid, but Medicaid is written in 1965.
Right.
And so a lot of its structure is still based on 1965 ideas about how things are going to work.
Yep.
So, one of the things when people say, why doesn't Medicare cover long-term care? Because that's in 1965, that's what daughters were for.
Interesting.
And so you get some coverage of disability under Medicaid, but not in home and community-based services until the 80s. So it's a slow evolution. It first covered intermediate care facilities in the 70s, which were like smaller institutions, and then it started covering home and community-based services.
Yeah.
So that has also been a slow evolution over time of moving Medicaid funding to where it should be.
Got it. Okay, and it sounds like we still have some work to do in this space. It's
Definitely.
far from solved.
Yes.
So from your perspective, why should community health centers be paying closer attention to disability policy right now?
I mean, I think because of their crucial role in not turning anyone away, in being the like safety net is overused, but the where everyone should be allowed to go and able to go and get the care that they need. That being such a crucial part of the mandate.
Yep.
I think we might get into this more, but a lot of healthcare remains really inaccessible to people with disabilities, and the places we've seen trying to make that better are the community health centers.
I think there is that constant commitment and intention, but I will also say, we have really wonderful partners in lots of different spaces, but I will give, some credit and some call out to some of our partners in the MCO and health plan space. Because some of them have really done a great job of leaning into their patient population, their beneficiary population, and then convening all the different stakeholders together to learn from each other. And what I have found in those conversations is that, first of all, there's constant learning. It's never, you're never sort of like, oh, we've done it, we've checked the box and it's done. But I think for all of the great work that's already been done and the policies that are in place, there's still so much more, and a lot of it does come down to, I think, those conversations, those stakeholder conversations to understand the true needs, whether it be the role of caregivers or just it's a different sort of cultural sensitivity, honestly, in a way.
Yeah.
Have you found that in the work that you've done, and sort of like, are there any experiences you've had in sort of like stakeholders connecting where there's been great progress that's made as a result of that, including how it might translate to policy?
Yes. When disability organizations and people with disabilities are meaningfully and actually involved in the planning process, in asking what problems they need solved, the biggest challenges you're going to face is when disability is an afterthought. When you build a whole system and then say, oh, I didn't realize that people with disabilities were going to show up and need services or want to get health care or want to get an education or anything like that. So I think that's most successful early on. And I would say to everybody in the healthcare system, including my friends at MCOs, that's not just when you're bidding on the contract, but also when you are executing on the contract.
Yeah, 100%. Well, and I not to, give them too much credit, but I'm really privileged to sit on sort of an advisory council, and truly, like, that's one of the things that I've appreciated most about just having that opportunity to learn from each other, but especially from partners and stakeholders and patients in the disability space where, they're incredible advocates. But unless there's the intention of actually bringing everyone together, you don't there's get it. No way. Exactly. And it's, again, I think in some cases it's not with ill intention. It's just you're not thinking the same way. But let me bring us back to a couple of other questions. Where do you think the biggest gaps between what policy assumes and what patients with disabilities actually experience exist?
Yeah, I think it's, well, one, I think people assume that because disability is seen as kind of a medical thing, that therefore healthcare already is accessible. That the doctor's office, of course, it's accessible. You know, even healthcare coverage. People assume, oh, all people with disabilities have healthcare coverage,
Right.
and that's never going to be in threat. And that's just like not the case at all. Our healthcare
Right.
system has the same sets of assumptions and biases that the broader society has.
Yep.
So one of the biggest problems people face is physical accessibility of a doctor's office
Yeah.
or even a hospital.
Yeah.
When people kind of assume, oh, aren't they built to? It's like, well, no.
Yeah.
For lots of different reasons, no, they're not.
Well, that's an interesting one, right? Because I think, like, generally people have some sense of like, okay, there has to be basic accessibility. Like, just from a, if you spent any time in a public space or helping to navigate a public space, it's like you have to have doorways that are wide enough. You have to have ramps. You have to have, like certain things like that. But to your point, that doesn't cover all bases. There's a lot of other things. So I don't know if you want to speak to that a little bit, but
so many examples.
Yeah.
I mean, okay, so let's say you can get in the building, probably. That doesn't mean you can get up onto the exam table.
Yeah.
That doesn't mean you can get accurately weighed, especially if you're taking a medication that is really dependent on that, your dosing. There's really important data that CDC has on breast cancer rates among women who use wheelchairs because mammography machines usually require you to stand for no other reason than that they're just built that way.
Right.
They could be built for you to sit. They're just not.
Yeah.
And so I think those are the examples of it's every single step of the way. And I think this also goes to the removal from society, the medicalization of disability and so a lot of times people focus on, oh, the disability that you have.
Right.
Without thinking of, oh, you also have a whole other human body
Yeah.
that's going to need preventive care and primary care and screenings.
Yeah.
So again, mammograms, also pap smears, prostate exams. These are screenings that people with disabilities just go without.
Yep.
And that's just talking about someone with like a physical disability.
Yeah. Well, it's interesting, even in terms of standards of care and sort of unintentional, I'll give unintended, but bias, where, sexual and reproductive health, things like that,
Absolutely.
where again, I'm not a clinician, but I remember sitting in conversations and thinking like, oh my gosh, like I just assumed that these are conversations and they should be, but I also understand why in some cases people are incorrectly making assumptions and the harm that comes from that.
Yeah.
So we have a lot of learning and work to do in this space, clearly. But so what are some of the most common barriers primary care providers, including health centers, are helping those with disabilities navigate day to day?
Yeah. So we talked a lot about physical barriers, but part of it is what we call attitudinal barriers. So at my company, we're working on a project on dental access. Community health centers are absolutely crucial in helping people with disabilities access dental care. There's not enough. We're still working on it.
Yeah.
But a lot of the things that we have found when surveys are done of dentists and they really tell the truth, the answer is, well, I didn't think this was the population I'd be serving when I went to dental school.
Really?
Yeah.
Oof. That's
it's rough.
That's a hard one. That's like, I mean, I don't want to, be overly judgmental or diminish, but that's.
Yeah, it's tough. It's tough. And so I don't think that's exclusive to dentists. I think there's many other clinicians and physicians who maybe have a patient population in mind, or they have an idea in mind of the type of people they will be helping.
So let me ask you a question to that end then. And for one thing, I think that a lot of people who are operating and working in the health center space are doing so because they actually do want to work in the population. They're very interested in the mission around caring for underserved communities, whether that's urban or rural. But things like the complexities of the patients and the sort of the challenge of addressing all of the different social drivers and everything that comes along with our patient population. Truthfully, on the, with my wonderful other hat, working with the Association of Clinicians for the Underserved, some of the work we've done on that side is really to be very clear and intentional about the fact that caring for underserved populations is actually its own specialty because it has the demands are totally different. Like if you're in a primary care setting, it's very different in an underserved community versus what it might look like in, a more resourced community, private practice, you name it. But I'm wondering, like, is that sort of an emerging specialty? And I mean, like, I don't know that you could really specialize because there's a really, really wide array that you'd be talking about in terms of the disability space. But is that kind of an emerging specialty, or is that something that you've seen or talked about in the provider space?
Like serving people with disabilities as a specialty?
Yeah, I mean, I guess so a lot of the things that we're talking about, and I don't know where it would exist in sort of an integrated care team, but it just feels a little like, is that going, if it doesn't exist already, like, is that an emerging space where someone is trained specifically to be able to be thoughtful and intentional about the needs, the wide spectrum of needs and just considerations.
Sure.
And how that fits across a wider care team.
Yeah. I mean, I will say a lot of healthcare providers of all different kinds end up becoming disability specialists because people talk. And when they find a good one, they tell their friends.
I can see that.
I've experienced this personally with my chronic illness of like, oh, okay, they're so great. And then everybody goes to them.
Right.
On the other hand, I think there could be some benefit in that to that being formalized, but we'd have to really think it through because, again, of the history of special programs, separate programs for people with disabilities.
Right.
When most people would just be able to want to go to the doctor and not have to go to the special one that has a huge waiting list because they actually know what they're talking about.
Right. Yeah, it's interesting. That's one, it's like this is where the brain trust across the ACH team, your team, but sort of like the wider the clinical space too, but just I don't know. There's something there where it's sort of like, it would be really interesting, even from a policy perspective, to sort of like, to me, it isn't a separateness; it's an integration.
Sure,
but it feels like it would potentially be something where there's a set of standards and competencies that are just sort of an expected and required part of the approach, which I think to some extent exists today already. But I think of, and it's not the same thing, but I think of those who are focusing on geriatric populations where like it's a specialty within a specialty, or it can be a specialty within primary care. It just depends on what you're talking about, but it's thinking about the population more broadly and intentionally about sort of what the needs are. But I digress. I'm taking us on a tangent. Just bringing us back around, what are some of the most common barriers? Oh no, I asked you that one. The next one is, are there policies that look good on paper but don't work in practice for this population?
So there's a thing that we talk about in disability policy, which is that it's really, really easy to create something in disability that you think is good, but is actually bad. And I should say not in disability. I should say for people with disabilities. And that usually happens when people with disabilities are not themselves consulted or asked what it is that they need.
Yep.
My favorite example of this is when I was working in spinal cord injury. If you ask the broader world, what do paralyzed people want? Oh, to walk. They want to walk. But if you ask them, they say, actually, no, what I want is bowel and bladder control.
Oh, yeah.
And then you raise that point, and everyone's like, oh, yeah, that's way more important than walking.
Right.
But the big news stories, the things that get attention, I'm making this robot,
Right.
So I think those are the things that in health policy, where you go astray is by not starting just asking what people actually need.
Yeah.
What actually matters instead of assuming you know.
Isn't that an incredible novel idea to just ask the people who are actually experiencing the scenario and the condition to be able to guide, what the needs and the policy are.
But in disability policy, it still is.
Yeah. I mean, to be honest, so that's one of the things, like this is one of the treasure gems in terms of the health center program that I think all of us come back to so repetitively, and it's the consumer majority board to do exactly what you're talking about, which is to say, like, yes, there's a structure, there's a framework that we have to follow as a part of 330 statute and what it is to be a health center and provide comprehensive care. But the wisdom is exactly what you just described, which is like, no, the consumer needs to be the one guiding, like, where do we take the services? What else does the community need? What are we dealing with in terms of stigma, or whether it's behavioral health or substance use disorder, or we need, better access to nutritious food, and can we do a community garden? But all of those things happen and are driven by the board. And then I think the other piece with health centers, at least, it's just, I think, so incredibly beautiful, but also invaluable, is the folks working at health centers, many of them live in the community. So they're also the ones who are seeing their patients at church, in the grocery store, wherever else, or just, in the education system. They're bringing that back to their employer. So, but it's fascinating to me, in a bad way, that this still is a problem where they're not engaging stakeholders, again, like you said, to just have the conversation, like, what is going to be most impactful and meaningful and helpful. I mean, like, that's the other thing I think with policy is, I want to believe, I don't know that it's always true, I want to believe that the purpose of policies is to help in some way. Sometimes we don't get that right. But well,
I think people think they're helping.
Yeah. But they're not.
Not always.
No.
Sometimes. But.
Well, I was going to say, is there anything in the policy space right now that you're really excited about in terms of, like, they're getting it right? Or are there more, they're trying, but they're not necessarily getting it right now?
Okay, this is a tough one in our current policy environment.
Yeah.
I'm sure there's an example.
Well, you can share one. I get it. I mean, it's an interesting environment right now, but you can share one where maybe the intention is good, but the impacts are going to be really problematic. I mean, we're encountering that a lot.
Sure. I mean, well, I think maybe an example is just the Medicaid work requirements from HR 1, where they say, oh, you're fine. We're carving you out. It's fine. Everything's going to be fine. No one's going to lose coverage except for people who can work and just refuse to. I'm like, okay, please.
Yeah.
Maybe that was too.
We'll see how
maybe
that works out.
Maybe that's not as good intention as you intended, as you meant it, the question to be. But that's what popped into my mind of folks thinking, we're just going to carve you out. People with disabilities are going to be totally fine.
Yeah. Well, at least we know that's the stated intention. And
that
so
is
we
true.
can come back and say, okay, this was the stated intention. And that's part of advocacy, right? Is this was the stated intention. It's not working out the way that it was intended. Here are the impacts and the problems. Let's figure out how to change things to make it better.
What you said many times in Congress was your goal. Okay.
Yeah, exactly. There's, like I said, there's always so much to learn too. So what does access get wrong when it comes to patients with disabilities?
I think we talked a lot about physical accessibility, but also coverage.
Yeah.
The assumption that people with disabilities have coverage because they're all on Medicare or Medicaid.
So let's talk about that more, because I think, like, even I certainly still have lots to learn in this space, but I do think there's that assumption, even for people who work in health policy. Like, I think there's this assumption that, like, oh no, this is a part of the population that's covered, and not that they don't have to worry, but that the vast majority of their needs are addressed.
Yeah. So with the Medicaid expansion, we've made a lot of progress in that area.
Yeah.
So if you think about Medicaid, the disability pathways are pretty much, it's hard to make any declarative statement in Medicaid, but pretty much through Supplemental Security Income, SSI.
Yep.
The SSI standards are very, very strict, not just on disability, but also on income and assets. So if you don't meet that, you're probably in the expansion population. Well, if you live in a state that hasn't expanded, then you're not covered. Now, you can access Medicare through SSDI, Social Security Disability Insurance, if you have a work history, but not everybody does.
Right.
So the combination of it's not just your disability, it's also your money and your work and your history.
So can you, just for folks that are not necessarily up on, everything from FPL to like the economics, but like, what does that look like for the average person? Or like, what is the threshold? What would basically disqualify you from being able to access?
Oh, through SSI?
Yeah.
$2,000.
$2,000.
That's the asset limit. $2,000.
Okay.
So think about, there's some exclusions, but think about And that's not just in cash, but in assets. Think about everything you own. You can have $2,000.
How does anyone qualify?
The people, they do qualify. It's very difficult to get coverage. It's very difficult to maintain. Like I said, there are exclusions for a home, a car,
Right.
that kind of thing.
Right.
Because folks need to maintain access to Medicaid, especially home and community-based services.
Yeah.
They decline work. They decline
Right.
promotions. They decline extra hours. And they figure it out.
Well, so this is one of those things where this is something else. I'm sure you've seen it too, Rachel, in health policy, or just in the system, where the policy actually works against what we're trying to achieve. And I think about it. I mean, there's lots of spaces for this, but I over the years have definitely encountered many patients who basically, they're working, they have, maybe they're a single parent, whatever their situation is, but they're working, they're maintaining, a family, and they're renting, whatever their situation is. But to your point, they don't want a promotion, because if they earn another $100 a month, then they lose their coverage, and they can't afford to have that happen for their kids, or for themselves if they have a chronic condition, whatever the case may be. While at the same time, a lot of times the conversation in the policy space is that we are trying to create these pathways for people to have, growth and upward mobility, and to come away from needing the support. But it basically sets up a situation where you can't, you're setting yourself up for failure, in so much as, the difference between $1,950 and 2001 is so little, but that's the difference of, what you're able to access for care and coverage at that point.
Yeah, and it's tough because it's almost like when we talk about the problems, we don't want to talk about them too much, because folks will use that as an example of like, oh, see, it's a poverty trap.
Right.
And so their policy solution is get rid of it.
Right.
The other thing is that also people who are maybe more skeptical of public health care programs say, well, we got to keep it for people who really need it. We need those income and asset limits so that we can make sure it's for people who really need it. Okay, well, when you say that, you create that cliff.
Right.
And then you call it a poverty trap.
Right.
So what if instead we broadened eligibility,
right,
and so that people wouldn't have to worry, so that people could start
right,
businesses, they could take more promotions. I mean, I'm a great example. I have ACA exchange coverage right now.
Mm-hmm.
If that didn't exist, would I have started a business? I don't know.
Yeah.
I probably would have had to go, nope, I need a regular employer.
Right.
I need employer coverage. I can't
right,
take that risk.
Yeah.
So when we don't try to ratchet down to, oh, we got to make sure it's really small and only for people who really need it. When we expand it,
right,
we can solve those problems
right,
that a lot of people say they want to solve.
Yeah, I think that there's, again, I say this a lot with health policy and you know, policy in general. There's a part of me that can understand and sympathize with policymakers in as much as most of these things require a scalpel, but the tool that they have is a sledgehammer.
Yeah.
And it's a problem
Mm-hmm.
because sledgehammers don't work when you need a scalpel. And I think health policy there's evidence of that everywhere you look. But I think it is highly ironic because, again, it sort of creates this situation where you're defeating the opportunity to actually achieve what it is that you want.
Yes.
But I will always believe in, I guess, U.S. ingenuity and innovation and persistence in terms of, like, we're going to get there.
We are. We're going to show up every day and do the best we can and try to make progress.
So coming back around to Medicaid, even with some of the challenges and the limitations and whatnot, why is it so foundational for people with disabilities?
Sure. I mean, I'll start with the fact that Medicaid is the primary payer of home and community-based services in the United States.
Yeah.
So that's your home care, personal care attendant, even employment supports. When we say home and community, it's both things. The things you need, a person might need daily to live their lives.
Right.
There's not coverage for that really through almost any other source,
Right.
but Medicaid.
Right.
So that's foundational. Then you add just that Medicaid is for people with lower incomes, people with disabilities either can't work or face employment discrimination,
Right.
or can't work very much. And so that is going to also lead to lower incomes, less access to healthcare.
Got it. So when policymakers talk about Medicaid changes or cuts, what are they often missing about the real world impact? My God, we could spend the entire conversation on this alone.
I mean, we talked about this a little bit. The assumption that people with disabilities are not in the expansion population.
Yeah.
Or the assumption that you can make cuts to Medicaid, and as long as you don't name disability programs in the law, they won't be affected. And we're already seeing
Yeah.
that in state legislative sessions right now, where the states are just looking at their overall books and saying, okay, well, we got to cut something because we don't have any more money. And that's going to also include disability services.
Yeah. Well, I was going to say, before we started on air chatting, I know we were talking a little bit about Nebraska and sort of the trailblazing that's going on in that state, and some of the concerns that we're already starting to see sort of play out. But just, I know that you have been doing a lot of kind of work and analysis around what you're seeing in different states. Are you seeing anything positive and balanced, obviously, with like things that are concerning, at least at this stage?
It's tough to say. I will say we're seeing some states are planning to try and work really hard to protect as many people as they can. California has an HR1 implementation plan that you can look up online. I do think the states that are trying to be the most careful are waiting for the interim final rule that's supposed to be out by June 1st.
Yep.
So there's that. So I'm hoping to see some more after that. But states are in a tough situation.
Yeah. Well, I think it's also paired with, we were in a different conversation, we were talking a little bit about just the timeline with HR1 and some of it being, okay, so January 1, 2027 is the day, but the reality is, even with work requirements, it's like that process has to start far earlier than that. And so, and then there is still guidance that is pending. There's so many different pieces that sort of fit together but are somewhat unknown right now.
Yes.
And so it's, I know for health centers it's really challenging. There are certain things that I think they are trying to anticipate redeterminations on a more often basis. Okay, so we sort of saw some of that after the pandemic with redetermination in general, but I think there are lots of other pieces to this that it's just sort of really precarious is one word we could use for it, but also just so troubling and concerning for patients. And then I think for health centers, sort of what that looks like from a financial solvency and sort of operations perspective. But we'll stay tuned because there's a lot to come on that one for sure.
But yeah, states and health centers and partners, they need information, and it's not always coming out. So in the statute, the guidance on those eligibility redeterminations was supposed to be by December 31st. It came out March 6th.
Yeah, I mean, I've never known the government to ever be off on their timeline. It's never happened before. Unfortunately, to your point, and again, I will give, the benefit of it's with good intentions, but it's complicated and it's really hard. And they have set a very aggressive timeline. So, and I think everyone is doing their best to abide by that timeline. But to your point, it's really, some things don't happen on time, as is often the case. And then the sort of domino effect that comes from that is, enough to make your head spin, I'll say. So let's think about positives.
Okay.
So what are they doing well in the broader health system? What are health centers? I think when I say they, what are health centers doing well in the broader in the broader system let me reverse this.
Okay.
What are health centers doing well that the broader health system isn't?
Well, when it came out, what are they doing well? I come back to that kind of trying to turn nobody away.
Yeah.
Trying to actually solve problems. We see it in dental, but also in other areas. I think, for example, last year, I'll try not to get too far into the details. Last year, HHS issued a reinterpretation of certain immigration laws that changed who a number of service providers could see, from Head Start, but also the community health centers. And we heard a lot of them really grappling with this, with their requirement to see everyone, and then this threat to their federal funding.
Yeah.
Focusing on their number one goal being to serve the community and to see everyone and to do that as much as possible and to keep the doors open. I think I'm not going to say other people don't do that,
Right.
But I think it's so clearly at the forefront of what they're trying to do in their communities.
Yeah, I appreciate you calling that out. I think I would echo that, health centers are so incredibly committed to mission, but they are equally committed to doing what they're told, meaning that because they're used to it. I mean, honestly, the accountability that health centers are required to follow and stand up to in terms of, financials, outcomes. I mean, the list is quite endless, but I think it is a struggle at times, but I know that, and I've watched over 20 years of doing this, they are constantly trying to make sure they're staying inside the lines and following rules, following the law, maintaining that accountability. And to some extent, I think that's been one of the challenges with HR1 is that they really just want to do it right.
Yeah.
They really just want to do it right and make sure that they can do then the best possible for their patients and their community. And again, I think to what you mentioned earlier, there are times where there just isn't more information or clarity around, well, how do we do this? Or how do we do this? How do we implement to make sure that we're following the rules and the laws and also following this other rule or law over here? So it's a really interesting time, but I'm really proud of and grateful to our members and health centers more broadly because that is a commitment that I have seen for my entire 20 years working with them. But I think that's a 60-year history that the program stands for itself in terms of, again, the accountability and transparency and really following the letter of the law. And I think that comes down to wanting to do the best they can for their patients and their community. So what does truly patient-centered care look like for someone with a disability?
I think it's kind of similar to lots of other patient-centered care and focuses on listening to them and what they need. But in disability, it might be even more having a little humility on what you know and what they know. Especially if someone's had a condition for many years or their whole life, they might come into that appointment knowing a lot more about it than that healthcare provider.
Yeah.
And that's not a situation that any healthcare provider is accustomed to being in. And so it takes a little bit of a change in attitude to say, oh, I might learn things from you. Let's work together to solve whatever problem you're facing right now. That's a little unique. But I also think that there's probably could be more of that in listening to all patients.
Yeah. Yes, I agree with you.
Now, I know that doctors and other healthcare providers are in a really tough environment with the 15-minute visit, with the pressure to get things done, with increasing paperwork. So we're all getting crunched by the broader system, but slowing down, figuring out what a patient needs, not assuming what they need, either when it comes to their healthcare or their accessibility.
Yeah. Well, and part of what you're getting at is value-based care. It's moving in the direction of value-based care, I think will take us closer in the direction that you're speaking to, which is, having more time and space to just be able to, treat the patient and engage and listen and learn versus, like you said, sort of the nope, 15 minutes, got to be on to the next. And I think, health centers, every health center is in a different sort of space on that path or journey. But I'm encouraged, and actually ACH has done a ton of work in terms of supporting the move in that direction because it's so important. And I guess, it absolutely kind of drives further at the mission in terms of, caring for the patients in the community.
Yeah. Well, I have another example. I remember when I was at the Epilepsy Foundation, our chief medical officer would talk about prescribing and how for her, it wasn't, well, here's the drug that works the best in your situation. It was like, okay, what is your life like?
Yeah.
One person might say, my job is way too important. I can't have any side effects during the day, but I can sleep 12 hours a night. Well, a new parent might have a totally different set of priorities, and that's part of the decision making of how you set their care. So I think that's another example of listening to a person's life, what their life is like and what their priorities are.
Well, and continuing to listen because we're human.
And it might change.
Yes, I was just going to say, we change, and I think, there's an interesting metaphor there with policy too, where that has to change too. Our world is changing. AI, there's so many different things. But I was going to ask you too, just in terms of, patient-centered care, but also sort of the role of caregivers, because I think that that's something else that is depends on the provider, but sometimes I think a little misunderstood, and or there are assumptions about, okay, well, I should be communicating with the caregiver instead of with the patient. And
yes, huge problem.
Yes, it differs from individual to individual, but please, I'd love to hear you speak to that a little bit.
Yeah, communicating with the caregiver instead of the patient, communicating with the translator instead of the patient, which is like possibly even worse, because they may not even have a relationship with that person at all. Again, but it also depends on the scenario and what's called for in that moment. Right. I also know caregivers who can be there to help speak up and defend and advocate and say, well, okay, well, what happens if this doesn't work? Then what are we doing next?
Right.
Or, no, remember when you took that drug and all these bad things happened?
Right.
They can help, in the best case scenario, be a, external hard drive of memories and extra energy to stand up and, fight for things. But also, again, they aren't the person.
Right.
Who's the patient.
Right. Well, and I think, again, it goes back to sort of a little bit of like scalpel sledgehammer. It's a very, it has to be an individual to individual response and approach. And the dynamics are different. There's so many different areas of difference and nuance that have to be taken into consideration, but which is part of the reason why I think, going back to something you said earlier, like having some amount of flexibility in the policy is really going to create the greatest opportunity for success.
Yes.
I think it's just releasing the death grip on it has to be this way or it has to be very black and white. There's not much in life that's black and white.
Every visit is the same.
Yes.
And I get why we have to build this way and why we have to have these codes, but human beings don't work like that.
Right. Yeah, 100%. And wow, what an interesting system we've built and created in the healthcare space. Well, last question for you. What's the one thing that you wish every policymaker understood about this issue?
About disability and health?
I think, yes, about disability and health, but floor is yours because that's yes, 100%, but if there are other things that you feel like, man.
Sure. I think access to care is worse than you think it is. And, but we don't need a new special program with a new special name. We need better access in what already exists. In the hospitals that already exist, in the community health centers that already exist, in the doctors out there in the community already serving people, in the dentists that just put up a shingle.
Yeah.
That's what's really going to change things. Now, I think we talked about earlier, if someone sort of becomes a specialist. I mean, don't get me wrong, we'll take it.
Right.
But wouldn't it be even better if you could just go to whatever provider is local to you?
Yeah.
And get the care that you need.
Right. Or now we're really going to go on a tangent, but maybe clinical education and training should include a more in-depth training around this. So literally every single provider has some baseline around competencies in the space. And, when I was talking about this doesn't have to be a person, but an integrated care team, this is just part of it. It's just part of what they do,
yes.
To your point. But it's funny, I love that you just said that because that's literally been a big part of our conversation lately, especially in the context of rural health, where there are so many different providers and health centers in particular that are already doing great work, that are creating that access. Is there more that we can do? Of course. Is there great opportunities in terms of technology? Yes, of course. And everybody wants to continue to evolve, to do more. But it isn't necessarily about something brand new and shiny and sparkly. It's really about investing in what we know works and building on that. And so I love that you just said that. It's perfect. Perfect. Tie it up with a bow for the conversation. Well, thank you so much. It's been such a great conversation. We're so grateful for your work. And honestly, there's a lot in this space. I think especially as we continue to see what happens with HR1, I'd love to have you back on and have another conversation about where things are. And then, honestly work together around how we can do better. I think, I appreciate you calling out some of the things that health centers are doing well, but there's always more that we can do and learn to do better. But thank you so much for joining us and for the great work that you're doing.
Happy to be here.
Great. Rachel, thank you so much for joining us and for helping ground this conversation in the realities people with disabilities face every day. If there's one takeaway, it's this. Disability policy isn't a side conversation. It's central to how our healthcare system works. And when policy falls short, it's not abstract. It shows up in missed care, delayed treatment, and barriers that shouldn't exist in the first place. For For policymakers, the challenge is clear. It's not just about expanding access on paper, it's about designing a system that actually works in practice. That means listening to patients, understanding how Medicaid and support services function in real life, and recognizing the role providers like community health centers play in holding the system together. Thanks to everyone for listening to Community Health Centers Unfiltered. If this conversation sparked something for you, we encourage you to share it and continue the discussion. And we can't wait to see you next time. Thanks.